Hello everyone, I would like to discuss today about consecutive exotropia. It's one of the complications of esotropia surgery and its prevalence is estimated to be at 4 to 27% depending on different studies and different reports. So regarding the preoperative evaluation for a patient presented with consecutive exotropia, firstly, history taking, we need to know the main complaint and the duration of outward deviation and the progression, whether it is still progressing or it is stable, and any reports of previous surgeries to make sure that the patient had esotropia before. And the preoperative pictures will help a lot to confirm the history of esotropia. Then regarding the examination, we need to check the best corrected visual acuity, alternate prism cover test at near, at distance, side gazes, and to identify if there is any pattern strabismus, any adduction limitations. All these points will help us in deciding whether the patient will need medial rectus advancement or we should tackle lateral rectus and do lateral rectus recession. Slit lamp examination also will help us to detect if there is any conjunctival scarring, any trace of recessed muscle, anterior and posterior segment examination of course, and force reduction test and force generation test also is helpful. In some cases we might need to do anterior segment OCT to detect exactly where is the medial rectus, and also MRI orbit in few cases. So all these information will help us in deciding whether the patient would need surgery or not, and what type of surgery, whether the patient will need medial rectus advancement, and that usually is needed in patients with limitation of adduction, or we should tackle lateral rectus and do lateral rectus recession. Also, the amount of deviation will help us in deciding which muscle and how many muscles we need to tackle to correct the whole deviation. Today's case is a case of consecutive exotropia, and I did medial rectus advancement plus resection of the stretched scar or the pseudotendon. You will realize that there is conjunctival adhesions and it's not easy to do the conjunctival opening. So in such cases you need to do limbal incision and you need to do a large limbal incision. Try to avoid the places where there are a lot of adhesions. So in such cases we might need to do larger opening to be able to reach and hook the muscle. Actually, that part of the surgery might need half of the time, so that very simple step that usually will not take more than 1 or 2 minutes, in re-surgeries it would take more time to do proper dissection and be able to reach the muscle. As you can see, there are a lot of adhesions between the conjunctiva and the episclera and sclera, and that can happen because of many causes. One of them, poor surgical technique, and sometimes the nature of the patient and how the tissue reacts with the surgery. Sometimes while dissecting the conjunctiva, you might have conjunctival buttonholing, especially with severe adhesion like this case. Try to preserve the conjunctival tissue as much as possible, and if you have any buttonholing, you can at the end do suturing and close the conjunctival buttonholes. Also in such cases there will be more bleeding, and you might need to do cauterization to be able to visualize the tissues properly. In such cases, usually the muscle will be more posterior from the limbus, and you might need to insert the hook far more posteriorly to reach the muscle. And during hooking the muscle and isolating the muscle, you need to be gentle, because sometimes there will be stretched scar or pseudotendon, and the muscle will be fragile, and the risk of lost muscle might be higher. Here I am cleaning the muscle, the intermuscular septum, and the tenon above the muscle. In such cases, you need to do more dissection posterior from the muscle insertion to facilitate advancing the muscle after isolating the muscle with bilateral 6-0 suture. In large measurements beyond 6 or 7 millimeters, it's preferable to do the measurement on 2 times, so you will have more accurate measurements. You need to reach the proper muscular tissue, so when you are isolating the muscle, you will isolate true muscle, not the tenon capsule, so the risk of stretched scar or muscle slippage will be less. After cleaning the muscle, you can figure out that there is part is a stretched scar or pseudotendon, and you can figure this out, that you can see the hook behind the muscle. It's like translucent tissue, not like the proper muscular tissue. So I did around 4 millimeter resection of that stretched scar or pseudotendon, so I will put the suture in the proper muscular tissue, so that will help in having more stable results and decreasing the chance of muscle slippage or stretched scar again in the future. After isolating the muscle using Vicryl 60 suture, I resected the pseudotendon part and I measured 5.5 millimeters from the limbus to advance the medial rectus to the original insertion. After securing the muscle to the sclera, 5.5 mm from the limbus at the original insertion of medial rectus muscle, I closed the conjunctiva with 80 Vicryl, making sure to close the conjunctival buttonholing as well. Thank you so much.